eye view of what meta-analysis is. And then at some stage, we will go into the depth of this. And even though some of you may have already seen these slides, but we will spend more time than what we usually do in an introductory session. And I think it will help many of you to grasp at least some of the preliminary things which are important for doing a meta-analysis. So I am going to start with definitions, and definition is always a problem, and people often get confused between what is systematic review and what is meta-analysis, how it fits with research cycle. And then we'll spend a little more time on steps involved in conducting systematic reviews and meta-analysis. So, as you know that there is so much information explosion, so many journals, more than 20,000, so many articles, that there is a need for a reader or a faculty or a student to separate what is unsound and insignificant from what is crucial and salient, and therefore you need summary. All of us look forward to summary whenever we begin with some research question or some question in our mind, and therefore two useful methods. Now there are many methods, but two commonly used methods are one called traditional or narrative review and another one called systematic review. So traditional used to be, and now even now it is broad, and there are no method section in traditional review. You will find at least most of the traditional review which you commonly read, they don't write about methodology. Nowadays there is some attempt to introduce methodology also in traditional review, but generally they don't have method section. And as we always say, that method section is the key to any scientific activity, because if you have method section, you can allow anybody to replicate whatever you have done. And that's one of the key criteria for any scientific activity. So reproducibility or replicability is essence of science. And if we don't write methods, obviously we are not allowing people to replicate or reproduce whatever results we have got. So that is a problem with traditional reviews. Write any particular way or methods to limit errors in conducting this review. The errors may be in the primary studies which they are reviewing, or it may be in the reviewing process. So it may be either way. Often they resort to vote counting. Vote counting means they just count how many studies are positive, how many studies are negative. So it is about corticosteroids in COVID-19. They will say how many trials are there, how many trials are in favor of corticosteroids, so they are positive. How many trials did not show any benefit of corticosteroids, so that they are negative. Often they will just count the number of positive studies, negative studies, even though this classification itself is problematic. But this is something which people used to do for sure. And this positive negative is basically decided upon by p-values. P-values less than 0.05 will be counted as positive, whereas p-value more than equal to or more than 0.05 was termed negative. And this is how they were used to understand or integrate knowledge from various studies. Now, they didn't use confidence interval traditionally. Now, of course, increasingly people are aware of this. But I must tell you, one of the main contribution of evidence-based practice is there is focus on confidence interval. There is focus on confidence interval also because of increasing number of meta-analysis, which was not there earlier. So this becomes a key component of any meta-analysis, and therefore, as you will see maybe in later lectures, that this has a very different flavor than just relying on p-values. So systematic review is defined as a research summary that addresses a focused clinical question in a structured, reproducible manner. The structure I'm going to present to you later, and reproducible because there is methodology written in the meta-analysis or systematic review. Therefore, you can reproduce whatever has been done if you follow that methodology. And the quantitative part of systematic review, which takes out average of the results of 2 or more studies, which means there is some kind of aggregation of the results of 2 or more studies. It is done statistically, and that statistical component or quantitative part of the systematic review is called meta-analysis. Now, I must tell you, there can be a systematic review without meta-analysis, because after doing an extensive search and assessment of quality of the studies, you found only one study which is really good, and you want to focus on that. Since there is only one study, you can't do meta-analysis because you need at least 2 or more studies. There can be meta-analysis without systematic review if it is a poorly conducted activity. So people may gather just a few studies from here and there without really focusing on the comprehensiveness of search, and do a poorly designed meta-analysis, which can be, which have been published also. I am aware of that, but they are not really systematic review. So there sometimes meta-analysis is done without systematic review. We recommend, everybody recommends that meta-analysis should be part of a systematic review, and not always. If there is only one study, it is not required. If it is purely on qualitative studies, then meta-analysis is not required. But if it is based on studies which are quantitative, and there are 2 or more studies, then meta-analysis is required. And one of our own story is that when I was in McMaster University, Canada, then I was really motivated to write a meta-analysis of randomized trials of role of surgery in primary supratentorial intracerebral hemorrhage. And this was one of my assignment, which I published also in Acta Neurologica Scandinavica. This also became a Cochrane review after people came to know. They asked me to turn it into a Cochrane review. And then Dr. Mendello, he also got in touch with me saying that, can I have a copy of your meta-analysis? We are planning a randomized trial, so we will at least see what can we gather from your meta-analysis, and don't repeat the mistakes which people have done earlier. Also, it will help us to calculate sample size based on the summary estimate of your study, of your meta-analysis. So yes, I shared with him. We met in a conference, and then we decided that we will work together on this topic. Then his trial was published in 2005. As you can imagine, it takes some years before you can complete a trial and publish it. So even though we met, I think in 1996, it took some 9 years before their trial was published. When they published it, then I again met him in Newcastle upon Tyne while visiting Edinburgh, and said, why don't we do? There was very useful conversation, which I'm not going to waste my time on. But then we decided to write a meta-analysis incorporating their study. So you can see this, and Mendello is a co-author and his statistician Barbara is also a co-author, and we published it in Cochrane in 2008. This was a revision of my previous Cochrane review, which was only with 4 trials, which was also in Acta Neurologica Scandinavica. So after having done this, we identified some more areas or some more gaps which requires a randomized trial. So they did another trial, which was again published in Lancet in 2013. And still there are some trials going on. I am aware that in Netherlands there is a multicentric trial going on. So one trial cannot answer everything. When you do meta-analysis, you identify some of areas of gaps, and therefore this becomes a research cycle. So you do a systematic review meta-analysis, you will summarize but also find gaps and some research questions. This leads to a research proposal, and the research proposal brings some new data which is subjected again to systematic review and meta-analysis. And it goes on and on till this area becomes so mature that more studies are not required. Perhaps the question has been answered. Remember that it is nothing but a review of literature. Generally, sometimes it's not published data, but also unpublished data, but it is a review and it helps to generate and focus research questions. It certainly strengthens your research proposal. So all the faculty members who want to write funding proposal, please include a meta-analysis. Only the other day, one of our colleague, Dr. Rai in dental, was going to present a research proposal in Department of Health Research. And I said, no, you first do a meta-analysis, because if you present the meta-analysis, systematic review and meta-analysis, that certainly takes you one step above all the rest. So you are already in the winning, frame. So you better do it. And she did it very quickly, even though it was not part of her previous submission, but in presentation, she used it, and I'm quite sure she will get funding as well. It also helps to summarize evidence for formulating guidelines. So you know that these days guidelines are everywhere, guidelines for COVID-19 treatment, guidelines for every condition which you can think of, for treatment, for diagnosis, and so on. And they often depend on, or it is now a requirement of a good guideline to depend on a systematic review of literature. This has impact on clinical practice. Sometimes, even before guidelines are framed or formulated based on systematic review, people become aware of research summary, and it starts impacting clinical practice. I will give you some example to motivate you to do this. But before that, you see Medical Research Council of UK says that applicants are encouraged to conduct a systematic review of available evidence. So when you write for funding, you have to do it. Canadian Institute of Health Research also encourages all grant recipients to publish systematic review. Similarly, consort guidelines, while you are writing report of a randomized trial, says you need to present trial results in relation to other randomized trials. This can best be achieved by including a formal systematic review in the results of discussion section of the report. So need for reviewing literature is doing this is, I think, quite obvious to you. You come to know what is known. You also come to know how certain we are with what we know, and what are things which we don't know, so that more research can be conducted in that area. Now, remember, systematic review or meta-analysis can be done on completed studies, but it can also be done on ongoing studies and future studies. Now, you will wonder how it is possible, but nowadays it is possible, because certainly all randomized trials have to be registered. So if you have willingness and your keenness to do a systematic review and meta-analysis, find out what studies are ongoing, write a protocol, publish the protocol even before the results of the studies are out, and follow that protocol to do the meta-analysis, systematic review and meta-analysis, which will be prospective meta-analysis. This is why there is a registration for meta-analysis also in what is called Prospero database. But before this thing started, and still most of the meta-analysis and systematic reviews are done on completed studies. So this is a retrospective exercise. And that is why results of meta-analysis sometimes are set to be confirmed in a large trial, which has been the usual story for many of these interventions. Now, you can do meta-analysis comparing two treatments based on.
Sir, I would like to know that if you want to not getting articles, so can you publish that protocol also, na?
Yes, you can publish the protocol. Protocol is Cochrane reviews always publish protocol first, right?
Okay.
So protocol, if it is published, it gives more strength to your meta-analysis. In fact, your meta-analysis is more likely to be published if there is already a published protocol. But not all meta-analysis require this, but Cochrane insists that you must publish a protocol in Cochrane library before you start working on your completing your review. You can do it by collecting data on groups of patients. So if you have patients, let's say you have a study where COVID-19 patients have been subjected to a randomized trial using, let's say, corticosteroid or no corticosteroid. You have the mortality data in corticosteroid group, you have the mortality data in no corticosteroid group. You may find that the mortality, let's say, is 10% in those who did not receive corticosteroids, and let's say it is 7% in those who received corticosteroid. Now, with these two percentages and the sample size which is there, or the numbers which you have, let's say, how many patients died out of how many in the corticosteroid group, how many patients died in the non-corticosteroid group. This is grouped data. You don't have individual patients data. You have data of the group, corticosteroid group and non-corticosteroid. Then you can enter this data in some software like RevMan and conduct meta-analysis that will be called the meta-analysis based on group data or conventional meta-analysis. But nowadays, increasingly, people are getting the master chart of all the studies. So what is a master chart? Master chart carries data of each patient along usually a row, and one row is devoted to one patient. So that master table or master chart nowadays usually saved in Excel or some statistical software is shared, collected together, and then joined in the form of a big file where, let's say, you may have 200 patients data from one study, another 400 from another study. So altogether, it may be 600 patients data. Or if you have 5 studies, maybe you have 2,000 patients data. And each row of the data belongs to one patient, one individual patient. Then you can do meta-analysis, which is called individual patient data meta-analysis. But in both, we are comparing two treatments. But, for example, COVID-19 has been treated with various types of corticosteroids, hydrocortisone, dexamethasone, methylprednisolone, sometimes oral, sometimes intravenous. The question is, which one is best? So there are multiple corticosteroids being talked about. I gave example of multiple sclerosis where there are at least 5, maybe now 6, 7, 8, 9 treatments which are available to prevent relapses. In corticosteroid example, you have 3 types of or 4 types of regimen which can be given to COVID-19 patients. And the question is, which one is best? then you are comparing multiple treatments. If you are comparing multiple treatment, then we should call it multiple treatment comparison meta-analysis. This is too long a name, so it is also called network meta-analysis because the figure which emerges from this looks like a network. So that is what is network meta-analysis. A network meta-analysis of corticosteroids in COVID-19 has already been published. I'm not sure how well they have done it, but it is already out in public domain. What type of studies can be subjected to systematic review and meta-analysis? I would say practically all types of studies. Clinical studies, epidemiological studies. It's being done even in meteorology, in nuclear physics, in economics, in business management. So basically, wherever scientific studies are carried out, if there are studies which are more than one type, then obviously they can join hands and or you can join them and conduct a meta-analysis. Or if there is, even if there is no meta-analysis, you can conduct a thorough systematic review. So all branches of science are doing it, practically all, and even economics and business management is doing it. You can do in epidemiological clinical studies on prevalence and incidence figures. We published recently on prevalence of neurological manifestations in COVID-19 in Neurology USA Journal. You can do it for diagnostic test studies. Some of our colleagues in RIMS have already published diagnostic test study meta-analysis. One of my, you can say, papers which I'm proud of is a systematic review, not a meta-analysis, systematic review of Glasgow Coma Scale, which is has a very good citation. And Glasgow people, when they had, I think, 100 years of Glasgow Coma Scale or something, they really alluded to my paper. You can do meta-analysis on prognosis study, etiology studies, interventional studies. And since all of you are teachers, I should also say that if you write a paper, or let's say you see papers on a topic, and there are multiple papers in medical education or any education for that matter, you can do meta-analysis of education studies as well. So one example which I will share with you is systematic review and meta-analysis. We did meta-analysis in this, is predictive values of measurements done in medical schools to predict future performance in medical practice. This was one of the first meta-analysis systematic review in the field of medical education. Not the first, but one of the first. Now, clinically, just to motivate you to do this, I will give you some examples to see how you or your residents can make clinical impact with systematic reviews. Now, one of the, I think this was my first meta-analysis and systematic review published in Journal of Neurology, Neurosurgery, Psychiatry, which is about dexamethasone treatment of acute bacterial meningitis. How strong is the evidence for routine use? This was also one of my assignment paper in McMaster University, which I converted into journal paper. This was quoted in by Yearbook of Infectious Diseases. And then there is a Center for Reviews and Dissemination, which is in University of York. And they also looked at our meta-analysis and picked up for just putting the abstract in their database with their CRD commentary, which was quite positive. Then I got in touch with, they asked me actually to give my data to them from Netherlands, a group working on the same topic. And they published Cochrane review, corticosteroids for acute bacterial meningitis, and then also in Lancet. And that was almost, you can say, practice-changing publication. So many other journals, they republished the abstract of this review highlighting the role of corticosteroid in bacterial meningitis. Similarly, anticonvulsant therapy for status epilepticus, this was one of my Cochrane review, which was published way back. I don't remember when, but then I revised it once. And this also was practice changing because diazepam was the first choice till that time. And then in my Cochrane review, I showed lorazepam is better. And that is when many journals, they again reproduced my abstract of my review in their own publications like American College of Physicians Journal Club, British Journal of Clinical Pharmacology. Editor wrote to me that Cochrane reviews are in electronic, can you make it paper review format? We want to publish this. So really I got a request from the editor to convert the Cochrane review into paper format, which I did, and that also got published. Annals of Emergency Medicine also picked up and said, no, this is the practice-changing thing. We will definitely put to highlight this in our publications with separate heading. But I think what example really I like to give is a meta-analysis and systematic review done by my resident. My resident in neurology in AIMS, Dr. Telangana, she presented a seminar. And I told her, look here, you have collected all the data which is there. If you are interested, it can be converted into meta-analysis. You all have already done systematic review practically. She said, yes, I will work on it if you help. So I helped her and she finally published it in Acta Neurologica Belgica, not a very high impact factor journal, but for a resident, this is quite good. She wanted to publish it early. And we recommended, which was a completely new information, that tenecteplase is an alternative to what is being used since 1995, alteplase, in thrombolysis of acute ischemic stroke patients. But our own residents didn't follow this. We still continued to use alteplase. Then when I asked them, why do you do that? And they said, up to date, writes this is an investigational therapy. I'm talking about 2019. So I looked at up to date and I found, yes, they are right. What it is writing is that alternative fibrinolytic agents such as tenecteplase under investigational therapy. I said, oh, so our residents are more impressed by up to date than by our own contributions. So I wrote a letter to one of my friend, Gordon Guyot, and he introduced me to somebody who edits this neurology part of up to date. So I wrote email to him. He's John, and I said, look here, up to date is used by my residents. You see, I said my residents. And tenecteplase, which is available in India, approved for both MI and stroke, but they are not using it because you write it is an investigational drug. Can you look at our meta-analysis, and if you are convinced, then change your statement in up to date. And then in July, that was happening in April, in July 2019, I was surprised to see, he didn't write to me, but I just checked when on a summer vacation, and I found that they have changed it. And they have changed it like this. Although not licensed in the US for thrombolysis in acute ischemic stroke treatment, there is moderate to high quality evidence that intravenous tenecteplase, and then they wrote a wrong dose because they don't use it. They wrote a dose which was for alteplase. So immediately I wrote back saying that, look here, thank you for changing your statement, but this dose is wrong. The very next day I checked, they had changed it. So sometimes they can make mistake. And then they gave reference, and reference 61 was our meta-analysis. So one resident, by conducting a systematic review and meta-analysis, changed text of electronic textbook, you can say, which is used all over the world. So in fact, I was invited to US to give a grand round in one of the hospitals in New York, where they all felt that actually US, by not licensing it, is depriving them of using something effective. So last example, perhaps surgery. I have already told you that this change also practice, because first time we showed that surgery has a role, and that we also corrected the misinterpretation of the Lancet study which Mendelo had published, because that was had a format which was negative. I'm not going to tell you the details, but we gave data to show that it really has a role, and people started getting convinced about that. And if you see, Mendelo is co-author, where we wrote some neurosurgeons interpret the results. He himself is a neurosurgeon. So we said they misinterpret the stitch trial as negative and justify denying neurosurgery to all kinds of patients with primary supratentorial intracerebral hemorrhage. This is plainly inaccurate. And then we gave reasons. So basically, people got convinced. Again, Annals of Internal Medicine picked it up, saying that, look here, we want to publish this abstract, which they did. Stroke Journal wrote to me, can you write a piece which we often publish as Cochrane Corner? And I did that. So it shows that you can change a lot of things. You can change practice if you do a good meta-analysis and systematic review. And doing this is not a big problem. Many of residents can also do it. Many of the faculty certainly can do it, and there is no reason for not doing it. And because if you are doing a study, often you will first do a systematic review, do your study, then again do a systematic review. So that is something which I try to encourage, because that is the way science will progress. Now, for conducting systematic review or meta-analysis, I always summarize as 6 steps. Though I can make it 7 steps, but to make it simple and concise, 6 steps. First S is specify the review question and also review methodology, which will be in the form of a protocol. So first step is writing a protocol. And one of the things in protocol is, right at that point, think about what if there is dissimilarity across the findings of different studies, also called heterogeneity. If there is heterogeneity across the results of the studies, what are the things which come to your mind as possible explanation for heterogeneity? Is it because different age groups respond differently? Is it because different genders respond differently? Is it because timing of the intervention or timing when the intervention is given may be a reason for different kinds of response or results? So you have to hypothesize, what if I find heterogeneity? And if we find heterogeneity, which factors? Is it quality of the study, like we say risk of bias? Is it characteristics of the patient? Is it characteristic of the way intervention is given? Maybe we are doing a corticosteroid in COVID-19 systematic review, but if we find differences, we will like to examine whether type of steroid is a factor in explaining heterogeneity. Is it that type of comparison is in fact a problem? So, or it is the way outcome has been measured. Is it short-term outcome will look different from long-term outcome? What reasons you are going to think where if you find heterogeneity across the studies? This should be mentioned in the protocol. So some people who write how to do or what are the steps of systematic review, they start with after review question, next important thing is pre-specify what factors may be responsible for heterogeneity if you find heterogeneity in your meta-analysis. So this is something should be written in the protocol. Why? Because once you have seen the results, then if you start speculating, that will be data driven, which doesn't carry as much importance as something which you pre-specify even before looking at the data. That is one S. I will come to it very briefly later on again. Second S is search comprehensively. Third S is selection with eligibility criteria. After search, you will get a whole lot of studies, thousands of studies, maybe. And then you have to select using some eligibility criteria of the studies. Then you have to scrutinize for risk of bias and similarity of results. As I told you, if there are dissimilarities or heterogeneity, then you have to explore causes for heterogeneity. Then synthesize. Synthesizing is nothing but taking out average. And then summarize. Summarize the quality and quantity of evidence and quality and quantity of effects. So let's take first one first. Review question or research question in your systematic review must specify if it is an intervention review, population, intervention, comparison, and outcome. This is very important acronym, PICO, population, intervention, comparison, and outcome, which comes at every stage. I told you it will come as a possible source of heterogeneity, or maybe type of patients, age, sex, type of intervention, type of comparison, or type of outcomes, may be explaining heterogeneity as well. So PICO is something which I'm sure you now remember. When I started, nobody was aware of what it is. Now you have to, in fact, do the search also using PICO. So review question is very important. Searching comprehensively. Now, when I say that, then it's not only electronic databases. Electronic databases, at least two databases you should search. In field of medicine, it is PubMed, which is nothing but it comes out from Medline, and Embase. At least these two, besides Cochrane Library. This is something which is minimum. In fact, if you look at assessment scales for quality of systematic reviews and meta-analysis, one of the popular one is MSTAR, which says at least two databases, namely PubMed and Embase, must have been searched. But that also is not enough. You should search other databases also. Why not Google Scholar as well? Why not Cochrane Library? Why not SciSearch? If you are doing on nursing interventions, then Sinhal, and so on. So there are many databases. When I started doing meta-analysis, you have seen we maybe in 1992-93, all journals were not indexed. Even now, all are not indexed. So you may have to do hand searching. Hand searching means you take a journal in your hand, flip through the pages, find out relevant studies. Now, this is not being done anymore because Cochrane collaboration, when it started, it created large volunteer base to look for good trials which are published in any journal, and they were looking for any trial, not for a particular trial, and then they were tagging and giving it to National Library of Medicine and also to Cochrane Library. So most of the trials which are published are now indexed. But still, you may have some proceedings of the conferences you have to look at page by page. If you are going to do it, also ask experts, look at conference proceedings. If you are doing it on some medicines, drugs, write to pharmaceutical companies. There are sometimes registries, like I know for stroke trials, there is a registry. For many trials, there are registries. So you can look at registries and also look at Cochrane Library. So that will give you search. Then you have to select studies using eligibility criteria. Now, one of the very important eligibility criteria is what study design you are going to use. So the question is, are you going to take only randomized control trials? Are you going to combine randomized trials and cohort studies? Are you going to take case control studies as well? Because the level and extent of bias in various designs is very different. It is generally not advisable to combine two different designs in one meta-analysis. You can have systematic review including all types of studies, but when you do meta-analysis, then combine randomized trials in one forest plot, cohort studies in another forest plot, case control studies in another forest plot. So if you do look at systematic review and meta-analysis of, I think, BCG vaccine, you will find that has all types of studies, but all in different forest plot. Now, if you find consistency across all the results, no problem. But if you don't, then you have to rely on higher randomized control trials as more reliable than other types of studies. And of course, you have to specify whether you have right population, intervention, comparison, and outcomes or not. So at the end, you will have a figure something like this, which is also called Prisma chart, where you will start with many studies, PubMed, Embase, Cochrane, you get 159. This is from one of our systematic review of association between mobile phone use and brain tumor. And you will get a lot of duplicates. Then you may get reviews, some meta-analysis also. Ultimately, we got 34 case control studies and 5 cohort studies. We didn't include the cohort studies in our meta-analysis because these 5 publications were from one cohort study. So we couldn't combine one cohort with any other cohort. So we only combined case control studies, which were 21 after excluding something which has been published repeatedly. So you have to do that. Then you look at risk of bias and similarity of results. In Cochrane framework, you have different biases: selection bias, measurement bias, loss to follow-up, which is attrition bias, performance bias, which is basically if there is a lack of blinding of caregivers or healthcare workers or patients, that can result in different degree of care provided to the patients. So people call it performance bias. Then confounding, and of course, you may have unblinded outcome assessment, which will also result in bias, which is called detection bias. After having seen biases, we will spend more time on each one of these later on in later lectures. Then you have to look at similarity of results. If they are not similar, that is heterogeneity. And I think that is very important to see. If you have heterogeneity, then there will be a big problem because you have to then explain what is the cause of heterogeneity. I don't know where does this sound come from. Sources of heterogeneity can be clinical, which means different kind of patients, methodological, which is different degree of bias in the studies, or sometimes statistical, which may be something which you can deal with statistically. So how do you assess homogeneity between study? One is you look at population intervention, comparison, and outcome. Now that you can do just by reading and making tabulations and see whether there are differences in population intervention, comparison, and outcome. You may think, why will it differ if you have selected studies based on population intervention, comparison, and outcome? Well, population may differ because average age may be different in different studies, types of population may be different, interventions may be different, because all may be corticosteroids, but some will be methylprednisolone, some will be dexamethasone, some will be hydrocortisone, and so on. If you want to include all corticosteroids, comparisons may be different and outcomes may also be different. Then you can use your eyeballs to look at point estimates. Point estimates are usually shown as a square in Cochrane reviews, which are in the center of the line, which is indicating the confidence interval. And you look at the point estimates. Also look at, I don't know what happens when I get this annotating thing, then it stops moving. So I have to perhaps reject such requests. Right. No. Yes. Look at overlap of confidence interval. And then you can also look at statistically. I will come and explain this later in more detail. I square is the one which is most relied upon these days. You can also do a statistical test, which again I will spend at least half hour lecture on heterogeneity later on. But I square gives you percentage of variance that is attributable to real differences in effect size. And more than 50% I square means substantial heterogeneity. That will require that you try to explain heterogeneity rather than just do a meta-analysis. So one example of this will perhaps help you to understand. This is our own meta-analysis, corticosteroids for acute bacterial meningitis. These dots which you see in the center, these are point estimates. And then lines on either side is confidence interval. Now you can see that arrows are there. Arrows means these lines could have gone further, but because the figure in RevMan is not able to incorporate these lines up to extending beyond this, so it just gives an arrow. But if you want to know exactly where does it go, you can see the numbers here. So the scale does not allow it to be extended further. Now, when we look at this, we look at the point estimates and see are they close to each other or not. We are not talking about on the same side of line of no difference. This vertical line is line of no difference. And it's not that all should be on the same side. Are they approximately close to each other or not? That is one thing we look at. Then we look at the lines. Lines are confidence intervals. Are they overlapping or not? Now, if you draw a line here, then all the trials will be crossed except perhaps this one. But if you draw a line at this end, then all trials will be crossed. So there is complete overlap at this point. Similarly, if you draw a line, maybe you have to draw here, then this trial will also be cut. So you can see how much overlap is there across these different studies. That will indicate the level of homogeneity. And then you have to do synthesis. I'm not going to do this exercise with you, but if it was offline class, I would have done this. That if class has 200, I have done this with some of you already. 200 boys and 100 girls. Boys have average weight of 70 kg, girls 40 kg. What is the average weight of the class? Many people think 70 plus 40, 110 divided by 2, which is 55. That is not correct because there are 200 boys. So you have to do 200 into 70 plus 100 into 40 divided by 300. So that is weighted average. When you take out average of different population size, you have to give weight according to the population size. Similarly, because studies have different sample size, you have to give different weights to different studies. You can give weight according to quality of the study or risk of bias. If there is too much bias in a study, you may exclude, which is like giving a weight of 0. So you exclude that study, that weight is 0. Or if you are including, then you may look at the sample size and also number of outcome events. Now, if it is a dichotomous outcome, and depending on this, there is a formula which calculates the weight. We will come to that in subsequent lectures, how we determine what is the weight of the study, but sample size and number of outcome events are the key to assigning weight to different studies. Then we have to go for summarizing it, quality and quantity of evidence, quality and quantity of effects. That is done using nowadays grade method. Now, grade method is itself a 3 days workshop. I had invited one of the pioneer of grade method, Dr. Gordon Guide, to AIMS New Delhi, who conducted 3-day workshop on grade methodology. So some of you may have attended, I don't know, but this was, I'm not going to cover, but if you are interested, you can read this paper, which we published in 2014, How to Read a Systematic Review and Meta-Analysis. It also goes into grade methodology to assess the strength of evidence which comes out from a meta-analysis. I'm not going to cover publication bias in detail. There will be one full lecture on this, so let us forget it. Just to say that funnel plot is one method, only one of several methods to check publication bias. So to summarize, because we have only 3 minutes more, systematic review and meta-analysis can help you to define research question, strengthen your proposal. You know that in hierarchy of evidence for interventions and probably for other situations also, it is the highest level of evidence and it has potential for clinical impact, changing clinical practice, as I have already shown with some examples. It is a time-consuming thing, but often a very gratifying experience. In fact, I don't know if I had not done meta-analysis, if I had to count with my efforts how many practice I have changed, I would have difficulty in counting because single studies very rarely change practice. But when you have the body of evidence pointing in a particular direction, it often is influential to change practice. So thank you very much. If you have any questions, please unmute and ask question.
Good evening, sir.
Good evening.
Sir, what does double arrow signify in that image of confidence interval, sir, that you saw just now?
Double arrow?
Yes, sir. What is the significance of double arrow in that image of confidence interval, sir?
I will explain. Let me bring that slide and then. Arrow is basically showing limitation of the graph. Graph is not able to. So look at this.
Yes, sir.
Now, double arrow, like this line has double arrow. One arrow on this side, one arrow on this side.
Yes, sir. Yes, sir. Third last line.
So if you look at the values here, one end of the one is the center, which is clearly here you can see one. One is at the center, right?
Yes.
That is the point estimate. Another one end should have been on 0.07 and one end should have been on 15.38, right?
Yes, sir.
15.38 will be somewhere here. You see the scale is only up to 10. So
yes, sir.
To show that the line extends beyond this, they have put an arrow, right? Just to indicate that line is not stopping here. It goes beyond this. You can see it should have ended at 15.38. Similarly,
Yes, sir.
here the label is up to 0.1, but actually the end is at 0.07. So it should have been somewhere beyond this. But this software gives only this much space for the figure. So figure is not able to accommodate these points. That's why arrows are shown. Is it clear?
Okay. Thank you, sir. Yes.
Who is asking this question? Good question.
Sir, myself, sir, Dr. Shobha, sir, from surgery department.
Oh, very good. Very good. Okay. Any other question?
Sir, Dr. Jayaprakash here, sir.
Yes.
As you said that we can do meta-analysis on 2 studies also.
Yes, yes.
Suppose that if you are getting 4 or 5 studies and all having different outcome,
Yeah.
then can we proceed?
No.
Yes. You see, let me stop. Let me stop sharing. You can proceed. I will give you example. If somebody is doing meta-analysis of intervention like exercise, which improves, let's say, regular yoga improves exercise capacity. So yoga is the intervention. People are young people like all of you, and the intervention is yoga. Comparison is no yoga, and outcome is exercise capacity. Now, exercise capacity has been measured, let's say, in different studies using different outcomes. One study has measured it by number of steps you can climb and how many times you can climb. Another study has measured it in a treadmill. What is the length which you can walk before feeling so breathless that you stop? Third study has used by distance which you can walk on a plane, and that may be in a different measure. And there may be another study which has a respirometer or something, some other instrument on which they have measured exercise capacity for using different measures. So all these outcomes are different. Now you want to do a meta-analysis of these studies. Can we do it? Answer is yes, we can do it. We can do it by converting all these measures into a common unit. And what will be that unit? That unit, I mean, for the sake of ease and for the sake of statistical, you can say, easiness, standard deviation is one such common unit. So all the results are expressed in standard deviation units, and then you combine in standard deviation units. After combining, you can express it in whatever unit you want to express it in, and that type of combination, that type of effect measure is called standardized mean difference. So standardized mean difference is converting all outcomes into standard deviation units and combining it. This is how you can do meta-analysis even if studies have different types of outcomes. Does it answer your question?
Yeah, sir. But I feel that I actually registered just a statin therapy meta-analysis of that randomized control trial, and I got 3 articles, and I mailed to all the authors, but I didn't get after 1 week. I didn't get any reply of that mail. In first article, the outcome was venous thromboembolism. In second article, it was a hospital length of hospital stay in ICU, hospital stay, and in third RCT, it was decrease in saturation level and CRP level, like that markers. So how I will proceed?
No, this will be difficult because only standardized mean difference will work if your outcome is continuous.
Yes.
You have only two outcomes which are potentially continuous but not necessarily normally distributed. The days in hospital are usually not normally distributed, so you will have problem there. But if you can get continuous data normally distributed in, but they may be different outcomes, but in different studies you can use standardized mean difference. In your case you cannot, because venous thromboembolism must be yes or no. It is a dichotomous outcome. So you may have difficulty in combining dichotomous outcome with continuous outcome. But if you have continuous outcomes, you can combine together.
Thank you, sir.
Or you see, you may have to get individual patient data. Then you can have the outcome of your choice.
No one is sending data.
If they don't send the data, then you can do systematic review, but maybe not able to do meta-analysis.
Okay. Thank you, sir.
There's a question in the chat box by Dr. Puspanjali, sir.
Yes. Can we use finer acronym for defining a research question? Yes, if you are going to do primary research raises a question about which study topic I should take, right? Because you are going to collect data, you have to have your own patients, you have to have some tests which are available or not available. So you have to check whether the study is feasible. It doesn't apply to systematic review or meta-analysis, but it applies to a primary study which you are going to do. It should be feasible, it should be interesting to you, there should be something novel, ethical, and relevant. So that is what final stands for. It is used for planning a primary study, a systematic review. Doesn't have to, it's always feasible. It is interesting, that's why you are going to do it. It should be novel, that is, of course, nobody should have done it earlier. There is no ethical question here. And of course, it should be relevant. You shouldn't do it for the sake of doing it. So all the components don't apply here. And therefore, it's good for research question of primary studies, doesn't apply to systematic review. Another question is, what does double arrow signify? I've already answered. Can we do a meta-analysis if we have observational studies only, no RCT? Yes, you can do it. You can do it, but it will be meta-analysis of observational studies. Many are published already. Observational studies have been published for blood pressure and outcomes like cardiovascular outcome. And it tallies very well with randomized controlled trial. So you can, there are studies, meta-analysis of observational studies, many of them. Can we do meta-analysis? Yes.
Sir,
Yes.
good evening, sir.
Good evening, Dr. Archana. Yes, please.
Sir, when we are doing a meta-analysis of observational study, how do we make a PICO statement? Like intervention and comparative will not be there.
Yeah. So it will be exposure and an outcome, right? So
Yes.
if you read my book, which is second edition of my book on evidence-based medicine, I think I have given at least 5 variations of PICO. So one of the variation is PEO, right? So it is population, exposure, and outcome. And that is good enough for observational studies if there is no intervention. If there is intervention, observational studies can be interventional also. Like many people in COVID-19, they just used erythromycin, chloroquine without random allocation, and they looked at the outcome. So they were observational studies. But there is intervention. So there should be then intervention, comparison, and outcome. But if you have observational studies which only looks at exposure, there is no comparison, then population, exposure, and outcome. There is another variation of that is called just POE, population and outcome. For example, if you want to do systematic review and meta-analysis of what is the 5-year survival of, let's say, cervical cancer stage 2.
Okay.
Only thing you know is population, and you want to know 5-year survival. So it is just P and O. There is no E either. So just imagine there can be many variations of PICO, and if you want to look at all the variations, these are for interventions. For diagnostic test, what is PICO? Then I stands for index test, and C is comparison test, usually gold standard. Like index test will be, for example, rapid antigen test. Comparison may be with RT-PCR. Of course, population is always same, patients suspected to have COVID, and outcome is you may want to know sensitivity and specificity of the test. So PICO works in
Observational studies.
test also. Yeah. So a lot of variations are there. This is just a way to remember so that you can change it according to your circumstance.
Thank you, sir.
Suppose on top our research question, we have some of retrospective studies and some of them are RCTs. So can we do club together in the same meta-analysis, or do we need to do them separately?
Question is, are they all interventional studies?
Yes, yes, more or less the same intervention is done. Some people have done it retrospectively over a large cohort, and some have done RCTs on a smaller cohort, smaller set of patients.
Right. So you should do meta-analysis of RCT and observational studies separately. However, suppose there is only one large observational study, and there are 5 randomized trials. Then as a form of sensitivity analysis, you can incorporate that and see whether results change if you include that observational studies. It's not that people have not done combined meta-analysis of observational and randomized trial. The problem is that when the results differ, usually one standard explanation for heterogeneity is risk of bias. Risk of bias is higher in observational studies compared to randomized trials, well-conducted randomized trials. In which case, you will be bound to do subgroup analysis, randomized trial separate, observational study separate. So even if you want to combine all of these, have a pre-specified hypothesis that if we find too much heterogeneity, then we will separately conduct meta-analysis of observational and randomized trials. But as first go, you might try and see whether there is heterogeneity or not. Often you will find a lot of heterogeneity if you combine different study designs.
Okay, sir. Thank you, sir.
No IEC required? Yes, no IEC is required for meta-analysis and systematic review, because you are doing it on published studies, or even if not published, already completed studies. How commonly is data abstraction done by 2 reviewers? How do journals check that? No, the journals depend on your statement. Always, all steps of meta-analysis should be done by 2 reviewers. We should be searching, selecting the studies, doing risk of bias, and also data extraction. I will come to that nitty-gritty in later lectures. All steps must be done by at least 2 reviewers, so that is a way to control bias in what is happening. Journals are we going to trust you. They are not going to ask for evidence, whether you have, where is the data, where is your Excel sheet, you send yours and both your friends also. They are not going to do that. If you have done it, I'll tell you one way we check it. I was reviewing a meta-analysis submitted from University of Nottingham to journal Stroke, which comes out from American Heart Association. So when I looked at it, they said that 2 reviewers have done it, but they did not give degree of agreement between the reviewers. And one way to express agreement, which I think we will cover in different session, is calculation of kappa, that is chance corrected agreement. So in my first comment, first round comment, I included one comment saying that since 2 reviewers have done it, please calculate kappa and incorporate that. Then I got kappa calculated, and the kappa which was calculated was 1.4 or something like this. So I said, sorry, I think they need to contact someone who knows how to calculate kappa. Kappa is never more than 1. And therefore, you need to redo it and then send it back to me. So they had to go back to somebody who knows how to do it. Then they did it and sent it back. And I approved publication in Stoke. It is published. So many people don't know, but they can be checked how to. Everything cannot be checked by the journal. They have to trust that you have done it. Okay, right? So thank you very much. I think that's a very good amount of interest, I should say. Any other question? Are we closed now? Amit?
Yes, sir. Yes, sir. Yes, sir.
Okay. Thank you very much. Thanks a lot.
Thank you, sir.
Thank you.